Stroke is not one disease, it's many diseases. Every stroke is different, every patient is different, but one thing is always true: time is brain. In large hospitals, stroke care is complex. You have multiple services, multiple handoffs, multiple drug decisions. That complexity creates risk, medication risk. This is where the pharmacist comes in, not as support, not as backup, as a core decision maker. In a 2,000-bed hospital, stroke pharmacists are specialized. They are trained in neurology, critical care, emergency medicine. They don't verify orders, they prevent disasters. Large hospitals don't move slowly, they move in parallel. Neurologists assess the brain, radiology reads images. Nurses manage access and monitoring. Emergency physicians stabilize. The pharmacist manages medication reality. What drugs are already on board? What drugs must be stopped? What drugs could kill the patient? This pharmacist is present during stroke activation, physically or virtually. They hear the same information at the same time. No delay, no second-hand interpretation. Stroke code is announced. The pharmacist responds immediately. They access the chart before anyone asks. They scan the medication list fast. Anticoagulants jump out first, always. Warfarin, apixaban, rivaroxaban, dabigatran. They ask critical questions. When was the last dose? Was renal function normal? Is adherence reliable? These answers decide treatment in minutes. Thrombolytics are unforgiving. They demand precision. The pharmacist confirms inclusion criteria: age, timing, imaging, then exclusions: bleeding history, recent surgery, blood pressure. Weight is verified carefully. Estimated weights are dangerous. Dose calculations are exact. No guessing, no rounding shortcuts. The pharmacist prepares the drug, often themselves. They label it clearly, they double-check everything. This is how intracranial hemorrhage is prevented. Some strokes bleed, others clot. Some patients arrive anticoagulated. Some arrive over-anticoagulated. Reversal is not simple. It's drug-specific. The pharmacist identifies the following: the anticoagulant, the dose, the timing, and the renal clearance. They recommend the right reversal agent. Not too much, not too little. They monitor lab responses, INR, anti-10A, clinical signs. These decisions can save a life or cost one. Large vessel strokes move fast, very fast. The pharmacist supports the pathway. They assess anesthesia medications, blood pressure agents, sedatives. They watch for hypertension, because low pressure kills penumbra. They review contrast safety, especially in kidney disease. They anticipate post-procedure medications before the patient returns. This prevents chaos later. Once in ICU, the pharmacist rounds daily. They adjust antihypertensives, targets change by hour. They manage cerebral edema therapy using either hypertonic saline or mannitol. They evaluate seizure risk. Not every stroke needs prophylaxis. They assess sedation choices. Too much hides neurologic decline. They monitor renal function, electrolytes, osmolality. This is critical thinking, not protocol clicking. Survival is only the beginning. The pharmacist helps design long-term prevention. Antiplatelet selection is individualized. Aspirin alone, dual therapy. Statins are intensified intentionally, not reflexively. Blood pressure regimens are simplified. Adherence matters. Atrial fibrillation is addressed. Anticoagulation timing is critical. This planning prevents recurrence, which is often worse than the first stroke. Transitions kill patients, not strokes. The pharmacist leads reconciliation. What should be stopped? What should continue? What was never indicated? Duplicate therapies are eliminated. High-risk drugs flagged. Clear discharge instructions are written, not vague ones. This reduces readmissions and mortality. Fear is everywhere after stroke. Confusion too. The pharmacist explains medications calmly. Why this drug matters, what happens if it's missed. Side effects are discussed honestly, no sugarcoating. Red flags are emphasized. When to return. Education improves adherence, adherence saves brains. In teaching hospitals, pharmacists educate residents, fellows, and students. They participate in research, stroke trials, protocol development. They analyze outcomes, door-to-needle times, bleeding rates. They help systems improve. Stroke care is evolving rapidly. Pharmacists are gaining prescriptive authority, protocol leadership. AI will assist dosing, but judgment remains human. In large academic centers, pharmacists are indispensable. They don't just support stroke care, they define it. Stroke care is teamwork, true teamwork, and the pharmacist is not optional. They save time, they save lives, they save brains. If this changed how you see pharmacy, like the video, share it, subscribe, because education saves lives. Thanks for watching. I will see you in the next video.